Hi guys, so I'm Ala. As you guys already know, our project is based on shunts in dead space and how to tell if it's a dead space problem or a shunt problem. Pulmonary diseases are associated with both, and treatment.
Hello, my name is Tamara Gubarak, and I'm going to be speaking on shunting versus dead space and the disease pathologies that go with each one.
What is a shunt? Perfusion and excess of ventilation. What is dead space? Ventilation and excess of perfusion. VQ ratio is the amount of air that reaches your alveoli divided by the amount of blood flow in the capillaries in your lungs. The V stands for ventilation and the Q stands for perfusion. Normal perfusion is 5 to 8 milliliters per kilogram. Normal VQ ratio is 0.8 to 1.0. Normal minute ventilation is 5 to 8 milliliters per kilogram, and normal cardiac output is 5 to 8 liters per minute. So how do we get the ratio? By dividing minute ventilation by the cardiac output.
So the key for normal gas exchange is to have matching ventilation and perfusion. So if we have alveoli with increased perfusion, then we should have increased ventilation to be in that range for the 0.8 to 1.0 in the VQ ratio. And if we have decreased perfusion, then we should see decreased ventilation. That's like, I guess, the ideal way to put it.
A shunt is the volume of air that is inhaled that does not take part in gas exchange. It is the perfusion of the lung without ventilation, where unoxygenated blood enters the systemic circulation and the VQ ratio is decreased. Indications of a shunt are refractory hypoxemia, where the patient is unresponsive to oxygen therapy and is requiring high FiO2 and high of PEEP. Their AA gradient is greater than 350 on greater than 60% of FiO2, their PF ratio is greater than 300, and their shunt calculation is greater than 20%. Dead space is a pathological condition which results when the alveoli of the lungs are perfused with blood as normal, but ventilation fails to supply the perfused regions. In other words, ventilation of the lungs without perfusion. Gas enters and leaves the lungs without coming in contact with blood, and the VQ ratio is increased. The way to detect a dead space problem is an increase in arterial to end-tidal CO2 gradient when utilizing end-tidal CO2 monitor. Arterial CO2 goes up and end-tidal goes down, creating a bigger gradient and resulting in developing dead space problem. Critical level is greater than 60% or 0.6. Shunts are once again decrease in the VQ ratio, where alveoli are collapsed and the blood passing by is not getting perfused. Some disease processes are pneumonia, atelectasis, and severe CHF associated with pulmonary edema. CHF is a left-to-right shunt problem. Blood from the left side of the heart passes to the right side of the heart and goes through the lungs instead of going out to the body. This results in perfusion being greater than ventilation due to the backup of pressure in the small blood vessels of the lungs, which cause the vessels to leak fluid. Once the blood stream Dead space is when there is an increase in the VQ ratio. The disease processes with dead space are pulmonary embolism, COPD, including emphysema. From previous slides that I've mentioned, we already know that emphysema is a dead space issue, With emphysema, we have hyperinflated alveoli that have air coming into them, but the gas flow in the middle of the alveoli aren't able to participate in gas exchange. This results in ventilation being greater than perfusion, and that creates chronic hypoxemia, which leads to pulmonary vasoconstriction, which is less amount of pulmonary capillary blood flow. In COPD patients, ventilation will exceed perfusion.
As we already know, the dead space formula is PACO minus PICO divided by PACO. When determining if we have increased dead space, utilizing the end-tidal CO2 is the key here. So normally in healthy lungs, our PaCO2 minus end-tidal CO2 should be a small difference. With increased dead space, though, however, we have a increased gradient. So our PaCO2 is increasing, but our end-tidal CO2 is decreasing, and that creates a bigger gradient. Maybe you guys are asking yourself questions like, why does the end-tidal CO2 go down and the arterial CO2 go up? Or why does the arterial to end CO2 gradient go up? So to answer your questions, we have oxygen that is coming into the alveoli, but there is no blood flow. So you exhale that gas right back out. And then that exhaled oxygen gas mixes with blood that has exchanged with gas. So you're exhaling carbon dioxide and oxygen gas that did not participate in gas exchange. So then for that reason, the oxygen that is being exhaled dilutes the amount of carbon dioxide being exhaled, and that's why you have that decreased end-tidal CO2 reading and increased gradient. When our patients don't respond to oxygen treatment, that is referred to as refractory hypoxemia, meaning a shunt. So regardless the amount of FiO2 we're going to give the patient, we're going to see very small changes in their oxygenation status. That is also indicated by a decrease in the PF ratio, increase in the A to A gradient, a decrease in the arterial to alveolar ratio. So in other words, shunts lead to dilution of arterial oxygenation, and dead space leads to decreased end-tidal CO2 due to the dilution of exhaled CO2. As I already mentioned in the previous slide, shunts do not respond to oxygen therapy. We need different therapy modalities to treat them. So basically, as I already said, blood passes by the alveoli and doesn't get ventilated, so it doesn't pick up the oxygen. It then passes through the capillary membrane, staying deoxygenated. It returns back to the left side of the heart, mixing with oxygenating blood, thus leading to venous admixture, and that leads to a decreased concentration of arterial oxygenation. And the treatment for shunts would be adding PEEP to recruit those collapsed alveoli, positive pressure. We're basically increasing our mean arterial pressure by increasing our PEEP to increase our surface area and improve oxygenation.